we'll go ahead and get this started. Well, first of all, we want to welcome Dr. Easterling to Downstate. You know, I'm sure he's a mainstay here, so we are familiar with him and certainly familiar with his work. On behalf of Dr. Riley, to whom you will see a lot more of after this week, he is certainly closing out some things that he was responsible for in his prior appointment at Vanderbilt University and several other institutions. So he's going to be most certainly more of a public face. So I don't want you guys to assume he's not here. He's certainly here, and he sends me to bring greetings, which of course I won't do as well as he can. But I want to introduce Dr. Easterling, as I mentioned. Dr. Easterling, excuse me as I use my my cheat sheet or cheat phone, is currently the Assistant Commissioner of the Center for Health Equity, Brooklyn Neighborhood Health Action Center, formerly known as the Brooklyn District Public Health Office at the NYC, or New York City Department of Health and Mental Hygiene. The mission of the Brooklyn Neighborhood Health Action Centers is to reduce health inequities and promote health equity in low-income and communities of color in New York City. Dr. Easterling is a Morehouse man, yes. As is Dr. Riley. Well, he's a medical school, so I don't know if that's the same classification, but we'll go with it for now. He received his MD from Rutgers, New Jersey Medical School, and an MPH in the Icahn School of Medicine at Sinai in New York. He completed his residency in family medicine at Jamaica Hospital, and these little things keep popping up on my phone, Jamaica Hospital Medical Center in Queens, New York, and the General Preventive Medicine residency at Icahn School of Medicine at Mount Sinai. So we certainly want to welcome Dr. Easterling and thank him for taking out time in his very busy schedule, as we all know. And thank you guys for taking out time in your very busy schedules to come and hear this exceptionally important talk on health inequalities that Dr. Joseph has promised me will happen on a very regular basis, and of certain something that is important to Brooklyn, something that is important to the state of New York. And we are certainly going to tackle them one at a time with Dr. Joseph's help, with Dr. Easterling's help, and all of you guys who are pillars of the community here at Downstate Medical Center. So thank you for coming, and without further ado, I will bring Dr. Easterling to the mic.
I was told that I can move around. I'm good? Okay, all right. Well, good afternoon, everyone. It's a pleasure to be with you this afternoon. It's a pleasure and an honor to be the first speaker for this seminar, as I understand that this is going to be an ongoing discussion about how we frame health equity within your institution, within the work that we do. And just a little side note and a side story, I was just in Seattle last week, and I was speaking at the Trust for Public Land. And this was the first time for the Trust for Public Land to actually have speakers talking about health equity. And one thing that I acknowledged and noted for that seminar was that it is important that this discourse is happening, right? We have to have conversations, have to have dialogue about what health equity is. And the more that we have organizations and institutions and nonprofits talking about this work, then the better that we're going to be coordinated and connected, right? Because we did not create this problem by ourselves, but we definitely need to be together in addressing the issue, right? And so that's one thing that I shared with them, and that's one thing I'm sharing with you all. And I will just say that the audience looked much different. There was less melanin in that audience. So, but it needs to be said, and we need to make sure that the message is consistent across. So I'm talking about health equity, and hopefully this will be a platform and a springboard about how all of our institutions are talking about health equity. So you'll see my title there, it's Advancing Health Equity. And I'm using the framework of public health, and we can change it around, whether you're talking about open space and parks, whether you're talking about clinical services, law, architect and engineer. There is a way that we need to look at health equity and understand what those structural barriers have been in place and how we need to eliminate or minimize them, right? And so thank you for the introduction. And so I'm going to get started. And hopefully I'll wrap this up in about 45 minutes so we can have more discourse and questions. What I always do in starting off, and many of us within the Department of Health, is framing this city, right? This city, it's a mecca of so many different things. A lot of people want to come here, but when we talk about the communities, when we look at this city, there are 59 neighborhoods. And there are many languages, there are many cultures, there are many foods, there are many people, and there are many experiences, even within the neighborhoods and even if you're within a certain ethnic group. And so because of that, then the way that we talk about health has to fit all the different diversities of people and experiences that we know exist, and there's not a one size fits all. And so in order to do that, we need to understand who is in the neighborhood. Right? And what's our baseline? What's happening now? And so when we talk about health and we look at that same map, but now we add on indicators around health and we say, well, what are the healthiest communities and what communities are not doing so well? And we look at that same map. And so those neighborhoods that are lighting up in a darker red, we can say that there's an issue there. There's a problem. And then when we look at more maps and we can say that, wow, those same neighborhoods are lighting up with other indicators, then that's even more of an issue, right? And so two of the indicators that we say across, within the public health world, what is a healthy community? Two of the indicators, one is infant mortality, and another is premature mortality, all right? Infant mortality is the rate in which we know that children are dying before the age of 1. Premature mortality, individuals are dying an early death. Right, so before the age of 65. And so if we look at North and Central Brooklyn, right, we can see Crown Heights, we see Bedford-Stuyvesant, we see East New York, we see Brownsville. Those rates are high there. And premature mortality the same. And the same is true for South Bronx. I don't think this is working. Yeah, there it is. South Bronx, East and Central Harlem, and the same thing is here in premature mortality, right? These are indicators, like what neighborhoods are doing well, what neighborhoods are not, right? So people know that. We know about infant mortality, right? And we've seen over the years that these rates have improved considerably, significantly across. So that's disparities, right? We could say this neighborhood compared to this group, but there's more to it when we talk about the neighborhood, and that's the conversation around inequities, right? This right here is just talking about what those disparities are for each of the neighborhoods. And so we're going to talk a little bit more about the disparities that we see. All right, so this is not working as I was hoping. All right, maybe I cannot. Oh, I'm not sure what happened. Okay, here we go. All right, back in action. All right, so we look at some other indicators. So we look at diabetes death, AIDS death, asthma hospitalizations for drug use. Do we see a pattern? It's all right, y'all can talk to me. This is the first one. We're shaking off the cobwebs. Y'all see a difference? Y'all see similarities? Same neighborhoods? Same neighborhoods, absolutely. Neighborhoods that we work in are the neighborhoods that our patients are coming from, or your patients are coming from, right? The same neighborhoods that we're providing community services. So I'm not saying anything new here, right? Everyone here, I think that you're very familiar with many of these rates, with this narrative, with this conversation. We didn't get to some more of the alarming things. So here we begin to look at some other social and economic indicators: elementary school absenteeism, poverty, unemployment, and jail incarceration. Wow, we got the health department talking about social and economic indicators. We're looking at it from the same neighborhoods. Do we see the same neighborhoods lighting up? Yeah. Same story. No difference. I mean, literally, we can take out the title of the map, and it could just be the same map, right? So then, this is the context. Again, we're talking about disparities right now. We didn't really get into the inequities just yet. Why are they there? And so this conversation, right, when we talk to our students, public health students or medical students, and we say that, people of color, whether Latino, whether they're black, and they have high rates of diabetes, obesity, that's one narrative that we hear quite a lot. The students do, but there's more to it. right? We cannot just explain it away by genetics or behavioral, the behaviors that are exhibited, lifestyle behaviors, lifestyle modification. There is more to it why we're seeing these higher rates, right? Because I started off by saying that these neighborhoods, multiple languages, foods, so it's not just what we eat, right? It's not just whether or not we're doing physical activity. There's more to that conversation. And so having that conversation is important, right? And so we also begin to look at firearm homicides and assault hospitalizations, right? This is non-fatal assault hospitalizations, right, that we're looking at. And so this is another way that we begin to talk about and insert the conversation about violence as a public health issue. Again, not a new term. CDC has already begun to look at that, begin to develop that framework. And here we are just trying to get into that conversation here in New York City about how we look at violence and who are the people within city agencies, within government, within the community that needs to be at the table to see how we reduce these issues, right? Same neighborhoods? No? Okay, all right. All right, okay, we getting started. We getting warmed up, don't worry. This is only my 5th slide, I'm thinking around 10 to 12, I'm gonna have a chorus. Yeah, exactly, that's what I'm hoping. So this thing about health equity, right? We keep hearing it. It's not a new term, right? But it's been pushed around a lot. In 2020, I think in Healthy People 2020, there was more about a conversation about health equity. Before that, we were talking about eliminating health disparities, and so there was all this conversation about what are we doing to eliminate health disparities. But the issue around health disparities is that we do not, again, have that context around what the inequities are in the neighborhood, that why we see the persistent in these disparities to begin with. And so if we say infant mortality rate, and for New York City, over the last 10 years, we have seen the infant mortality rate drop from 10 to 4, right, overall in the city. Great. Congratulations, New York City. You have done a wonderful job. But then when we stretch out and we say white versus black babies are dying almost 3 times as much as white babies. That's the inequity. That's more than just saying, all right, that black mothers don't love their babies, that there are no resources in the neighborhoods. There's something more to that story. And so why is it that all residents, all New Yorkers do not have the same opportunities for health? And that's the conversation around health equity. And that's what we need to uncover. And it's not going to be an easy conversation. But if we're truly committed to improving the health of all New Yorkers, we have to have that conversation. And so that's where it starts. Before it was just, we need to close the gap. We need to close the gap. But the more that we improved, we saw that gap has widened. And so over the last 10, 12 years, the Brooklyn District Public Health Office here in North and Central Brooklyn has really been working to eliminate those health disparities. But what we've seen is that we've actually made some things worse. We've seen that some neighborhoods are doing better and some are not doing as well because we haven't targeted our resources in a way that have been equitable. So equity is a different conversation than equality, right? Because you see equality, everyone gets the same. Equity says that we know that some people are starting from a worse position than others, that they need more just so we can level the playing field. Equity is a different conversation, and we have to be committed to the equity conversation. But also that means that we need to understand and be transparent about what the reality is, right? So in order to talk about equity, let's frame it. Let's begin to understand how we get here. To get here, some of the things that we've been talking about internally within our agency is, well, what's our approach to health equity? What are the components to really building out a health equity framework, right? And then what are the things that we need to do internally for our own staff so we can begin to address some of the biases that have existed? I mean, we've gone out to the community, we've done community engagement, and many times we keep hearing, the health department has been complicit in my own oppression. We still hear that today, actually. We actually got a blog post that said that we were doing that with working with doulas, community-based doulas. And that's the health department, right? And so I'm sure there are others that folks in the community are thinking that other institutions and agencies are not helping to really connect and improve the capacity of the community to do their work, i.e. self-determination, i.e. empowerment, right? And so that's the conversation that we're trying to have now, right? How do we correct our own wrongs? What are the things that we're doing that are perceived as oppressive, discrimination, right? How are we not elevating certain voices in the conversation and amplifying those voices so we know how that's going to inform our work, right? That's beginning to really get to understand what we've done, what's been inequitable, and how we reach equity, right? So this isn't new, and I think many people have seen this model, the SocioEconomic Model. And again, this is a conversation that wasn't even started by the current commissioner, Dr. Mary T. Bassett. This was a conversation that was started by previous commissioner, Dr. Tom Frieden, also former CDC director, and beginning to understand and delineate between what are the factors at an individual level, interpersonal level, also understanding what's at the organization and community level. And then when we understand what is leading to the higher rates of disparities and those inequities, more than 65% are really coming from the community and organizational level, not at the individual level, not in lifestyle modification, not talking about the behaviors and the choices that we make at our individual and interpersonal level. It's really around those structural. That's what's really leading to those disparities. So what are the levers that we need to pull and push on to really address the policies, the institutions, and the organizations that we work within? Because those structural factors that have been in place for decades, maybe centuries, are still in place now, right? So what do we need to do to transform those policies that have been in place, right? So over the last 2 decades, the last 20 years, there's been more research to talk about the pathways to health, right? Again, I said that this isn't a new conversation. Didn't start within this current administration, but 2 administrations ago, to really understand what are those pathways that are leading to poor health and bad health, right? And so you'll see that here the personal characteristics, biological attributes, psychosocial resources, material resources, what we have at our disposal at the individual level, very small factor in this whole conversation around how neighborhoods see their pathway to health, right? There are physical environments that we know about, environmental exposures like air pollution, access to parks, healthy food, fruits and vegetables within our neighborhood. And we're not just talking about food deserts. We're talking about what? We're talking about the plethora of unhealthy food in neighborhoods, right? We're talking about what our built environment looks like. Aesthetic quality, natural spaces, quality of housing, affordability and accessibility, quality housing, right? Leading to our health, the health outcomes that we're seeing. So the neighborhood social environments, safety, violence within my neighborhood, the social connection and cohesions, and we know that very well, right? The interconnectedness of neighborhoods is really important. Many of us relied on that. Depending on who's in the house or who's in the community, who's my neighbor, all that mattered, right? And figuring out a way of how we truly measure that and understand what the impact is around health is important for us. Local institutions and norms, right? So programming, whether it's an open space, whether it's culture institutions, African drumming, to dance class, those local institutions are very important for neighborhoods, for childhood development, and teaching about leadership, and teaching about skills that they're going to need going forward. And so being able to understand what that means, and then seeing how those are the difference, and that's what leads to good health and bad health, right? But going really upstream is understanding what some of those discriminatory policies, historically and contemporary, has led to the stress and ultimately poor health. This is a framework that's been worked out by many researchers. And so these are the things, and this is what we're trying to push. I mean, we've been doing a lot more research around the individual and the interpersonal. We look at racism only from an individual, and particularly more race, not racism, right? We say race, what are the differences between black and white, between this group and that group, right? And again, it does not add into this context about what the difference is within neighborhoods and the environment by which people are living in, right? And so we've only been telling part of the story. And so this narrative has been missing so much. And then when we teach that to our students, and then they become professionals, whether they're psychologists or they're physicians or nurses, then because this is the only thing that they know, then this leads to the stereotypes and the discrimination that we see in our healthcare industry. We have to add this part to the conversation. And so then people will understand, well, if a patient of mine is coming from Bedford-Stuyvesant, they're coming from Brownsville or East New York, then having this understanding of like what's happening from housing. So if we know that there's a 70% rate of water leaks, rats and rodents within NYCHA developments, there are about 8 developments within Brownsville, and I have a patient who's coming in with multiple asthma exacerbations, there's not me keep telling that patient to do this and do that. What are the levers that I can to pull on to make sure that I'm changing the environment? That's the conversation that we have to have now. It's not just saying, you know, Miss X or Mr. M, do this or do that. They're trying, and there are other conversations that they're probably having, whether it's with, you know, ACS or someone else. And so think about all the instructions that are being placed on them, all the burden that's being placed on them to fix their environment, right? So we've been thinking about different frameworks for the health department about how we look at health, right? And some of the things, and we're using some of the, you know, language that we've seen before, emerging public health, current public health, and you might have seen some of this language, particularly within communicable diseases, right? We talk about emerging infections and what's current and what we know about now and what's more emerging. But if we look at public health in a much broader scheme, whether it's communicable or non-communicable, right? And then we begin to understand, well, going back to that previous slide, what are the living conditions? So the physical environment, the social environment, economic and service. What are the things that we're working on now? I mean, we focus a lot on health outcomes. So what do I do around diabetes? And typically, what's the typical approach that we do around health outcomes? You just shout out to me. We had the 10th slide, so now I'm expecting some call and response. What do we do around disease and injury? What do we do? Typically. Individual outcomes, right? So then based on those individual outcomes, then what do we begin to do? What are some of our interventions? Typically. Education. We're always educating the individual around their disease, right? And then what do we do? So awareness is one, right? We always do awareness. We want to make sure we got education, health education. Make sure you know about your numbers. Make sure you know how to, you measure your numbers, things like that. What else do we do? Lifestyle modifications, right? So we'll throw out what? We'll throw out some cooking classes. Oh, make sure you come to the Zumba class. What else? What else do we do? Medication, right? So it's all about clinical, all right? So access to care. We want to educate you. We want to get you to your doctor. And at the same time, we also want to make sure that you're doing this class, you're doing that class, you know how to pick your groceries, and then you cook the groceries, and you're also taking some education class. So that's that's our current. So typically what we do is we wait for you to have a problem, right? We wait for the issue. We are much downstream, right? And then what the issue is that then we get back to those maps and we say, all right, well, man, like, why is Bed-Stuy have all these people with diabetes? Why Brownsville, all these issues? We waited for you to have it, now you have it. I'm like, oh, wow, y'all got issues. That's the conversation. That's what we hear. You look at whether it's the Daily News or anything, New York Times, and you'll see that that's the conversation when we look at neighborhoods. So we waited for everyone to have diabetes and have hypertension, obesity, and everyone to have these issues. But then we begin to say, well, what aren't you doing? Why you have this issue? What's going on? But we're not going back to this. We're not going to the living the conditions. What were the institutional power and policies that were in place to cause that divide in the first place, right? So in our framework, right? And so this is what we're beginning to list out now is, so we're taking this framework and we're saying, all right, so what are the levers that we have within our agency and then other city agencies to begin to address some of the living conditions, right? So, and that's not even as upstream as we can go. We're just looking at the neighborhood level, the physical environment, the social environment, right? There are opportunities there to make some changes, right? But then we need to even go back before that. And there's a conversation that needs to be had about class, race and ethnicity, immigration status and how, the presence of those identification impacts whether or not you receive services, why you receive certain resources or not, and what those inequities are. Why are they even present? And then that gets more to our institutional power. Who's present to even advocate for themselves? Who has the ability to do that? Do I know where those conversations are even happening? I mean, my vote is one thing, but after my vote, what's the ability for me to continue to have that conversation with my elected official? Who do I go to with my city agencies? 311, if I call about a maintenance issue, when are you going to respond? So the number of maintenance, the number of maintenance logs for Brownsville are 2 to 4 times that you see in Park Slope. Why? Why is there a difference in what gets fixed in Brownsville than what gets fixed in Park Slope? All right. So I mean, those are some of the things around institutional. That's not something that an individual, that an awareness could fix, right? That's not something like a class can fix, or even clinical service. Medication can't fix that, right? So it's shifting that conversation away from a medical framework and really talking about what the equity framework is, right? So this is sort of big things, right? Like, and we can really get a little bit deeper into the institutions. So institutionalizing racism. And I'm sure many of you have done this as well, but this past weekend, I just took a trip to DC and I had a chance to go to the National Museum of African American Museum, and I literally only got to the first floor. And I couldn't go in. I mean, it was like 2 hours that I was just there, and I couldn't even get upstairs. So, I have to go back. But it really, and I had this public health frame mind to it because I was actually there for work, and I had a chance to sort of look at, looking at enslavement of Africans and Reconstruction. So if we're going to talk about equity, and if we're going to add equity frameworks into our conversation, then what's a component of the conversation? So when we talk about it, we have to understand that structural racism has played a huge role in why we're seeing the inequities, right? So whether you agree or you don't agree, there's enough evidence to point to it, right? And so then we have to understand, well, where does the conversation start? It doesn't start now, right, within the last century. Within the last decade, we're talking about much further back. And understanding the impact of the enslavement during the chattel slavery all the way up to now, to present day, right? And so this is, and I'm sharing this with you, but this is a conversation that we're having internally. So don't just think that I'm coming out, oh, wow, he's talking about racism, he's talking about, no, this is a struggle that we're having within the agency, right? And so I'm sharing this with you so then that hopefully someone within your ranks will then have this, so we can have this discourse. Because this has to be an internal conversation. Where are we? Are you even on page with this? If not, why not? We have to struggle. And so I'm just sharing this. This is sort of a transparency, open doors for an open our shutters so you can see inside our agency. This is a struggle for us. And for some of us, we don't even know how to have this conversation, right? How we talk about the enslavement of Africans, and then how that has impacted the health that we see now today, right? And so we've been trying to frame this within the structural racism conversation, right? So it doesn't seem like, well, this is not putting blame on anyone. That's not the conversation. The conversation is understanding, well, the outcome is that we all want to improve health of all New Yorkers. Well, we need to understand, well, what have been some of those historical factors that have led to the outcomes that we see today. And then to broaden that conversation is that we can point to Sandy, we can point to Ebola, that it wasn't earmarked for just any one person. Any one of us could be in a situation where we're experiencing a discrimination or an inequitable situation. So this is a much broader conversation, whatever the disease is or whatever the injury is. Whether we're talking about bicycles, whether we're talking about Ebola, whether we're talking about a superstorm like Sandy, I mean, this can really impact all of us. So if we're going to really address inequity, if we really start with how the enslavement of Africans in the Reconstruction period has impacted people of color, that this will improve equity for everyone, right? And that's how we frame it. Like, how do we really reach a goal of health equity for all people? And that's what the definition of health equity was. It wasn't just for people of color. Wasn't people who are in low poverty neighborhoods. We're talking about everybody. How do we level the playing field, right? So for us to talk about structural racism, we talk about it in a way that, one, we want to understand that the enslavement of African people started with the dehumanization of people. So how do we unlift that veil? How do we recorrect that? Right? The difference is not in, just saying based on your color, that proves your inferiority. And do we still see that today? Where do we see that today? And that's how we frame the conversation. Where do we see it today in 2017 that people of color are being dehumanized? And then we fast forward and we talk about police brutality. And we talk about the interactions between the police killings and the engagement of black men on the streets. That is an example, real day today, right? And so now we begin to unpack that a little bit more, and we talk about then, okay, how would that translate to the health outcomes? How does that translate to the work that we're doing now, right? Just so you can understand our conversations and how we're really trying to address this. So we all agree that the dehumanization of people of African descent is still happening today in 2017, right? So this isn't something that happened in 1619 alone and it stopped. We're talking about it moved on and it carried generations. This is an intergenerational issue. We're not just talking about in the 16th, 17th century, right? So then we go on to the development of black codes and the sharecroppings and mass lynchings. And so one, we talk about, all right, the black codes, well, Reconstruction was supposed to be a positive period. We saw upward mobility of folks, people of African descent. But what are other things? On the other side, we saw the development of black codes. And the black code said that what it did was it criminalized vagrancy, unemployment, people who didn't have a house. Oh, do we see that today? We absolutely see that today. Where do we see that now? In what neighborhoods do we see that more often than other neighborhoods? Right? Right. Call and response. Somebody woke up. I told you it was going to happen. Right? So this is the conversation about structural racism. That historically we've had these discrimination policies in place, and contemporarily we're still seeing them today. And how is it showing up in our work? And that's the conversation where it gets really tense. Like, how are we getting resources to certain neighborhoods, but because the dehumanization, because of these codes are in place, then how are we allocating resources? Are we just saying, all right, everybody should just get one of this, two of that? Or are we saying that this neighborhood, we need to have a place-based approach because we know that we've seen the effects of slavery, the black codes, the Jim Crow period, the new Jim Crow period, et cetera, on and on, right? And then the other thing that we lift up is one of the things that we understand that advocacy is so important, right? Advocacy is super important, particularly in neighborhoods. Not only do I want sanitation to come out, what about the rats that are in my neighborhood? What about the streets? I got all these bumps. Who's going to repave my street? That's from advocacy. That's people showing up at community boards, making sure that we don't have a liquor store in every corner, right? That's advocacy. But what's the impact of mass incarceration and taking in 3.5 to 10 times of the population in jail are people of color, black men. So who's going to be advocating for them? And how can they advocate for their neighborhoods if when they come out, they're unable to vote? Or there's policies that are delaying or putting barriers that they know they could vote, but you're making it difficult for them to vote. So how is it showing up today, right? These are things that we know have happened, documented in our history books. We talk about it. It may not be in our history books, but we talk about it anyway. And so what's the opportunity for us to understand and peel back what's happening now, right? In our work, and I think that this is the conversation you can have in your work. So residential segregation. So this is really important for us. So we took out one piece of the work and really began to look at, structural racism, and begin to look at residential segregation. This is not new. I mean, folks have seen the redlining maps, and they've seen how they have impacted the clustering and the targeting of certain neighborhoods to ensure that black people didn't live in certain neighborhoods. This has been going on. I mean, the Federal Housing Administration, doesn't happen now, supposedly. I was almost there. It's all right. It's all right. Yeah, I got it. Yep, call and response. I told you I was going I knew it was going to happen. All right. And so you look at just this is not a health outcome. This is residential segregation. Which map does this look like? All of them. All the other indicators I showed you, right? And so as they were putting people in certain neighborhoods, what they also did was we could put the quality of certain hospitals, whether it's interfaith, whether you're looking at Brookdale, the poor, they did the rankings of the hospitals just recently, and then you just map them out. They're going to end the poor quality hospitals end up in those circles, right? So it wasn't just residential segregation. What they said was, all right, we're going to get everybody in these neighborhoods, and then the resources are going to be less or poor quality or non-existent, right? And so the conversation, so we're not even talking about health yet, but we're just saying, what's my real opportunity to be healthy? You know what I need, my basic necessity, what my basic needs are, right? Education, right? If we begin to rank schools, we'll see that the poor quality schools are in those same circles, right? We already know about the hospitals. You know about them, right? I'm not saying your hospital, I'm sorry. I'm not saying your hospital, right? But no, I'm not. But that's the conversation, right? Like, what else are in these neighborhoods that people have access to or don't have access to, right? And so when we talk about racism, like in our conversation, we talk about it as a systematic power structure, right? Racism is the power and oppression that structures opportunities and assigns value based on race, unfairly disadvantaging people of color. So racial oppression, while unfairly advantaging whites, right? And so going back, so one of the things that, as I was reading through a recent publication, one of the things that I just learned was about Social Security Administration. I didn't know this, but when Social Security Administration was first developed and implemented, it excluded people who were doing agricultural work and also who were doing like labor, like house servants and things of that nature. And the people who were primarily who had those jobs were people of color. And so by unfairly excluding people of color, then how does that build asset and wealth, right? It excluded people from building that type of wealth, right? And so because of that, then we're seeing now that they did not have the same opportunities that everyone else did. I don't know if there was an amendment to agriculture workers, and I don't know if anybody knows that. But I did read that, when Social Security Administration first came out, they did not cover those type of jobs. But I'm going to look into whether or not that was changed. And I'm hoping it was, and I think it was, but I just remember seeing that. So these root causes of inequity. So policies that created all types of systems of unbalanced power and privilege caused by historical practice of exclusion, discrimination across the life course, which led to the geographic concentration of poverty and hypersegregation, right? And so i.e. I'm talking about residential segregation, but the pathway, right? So if I'm in a neighborhood, or if we're talking about a patient who is in a neighborhood that has been in a geographic concentration of poverty and hypersegregation, then what's the opportunity for that mother or that father or whomever, grandmother, grandfather, to make a decision about housing, right? Very limited. Then they're also burdened with the fact of making a choice about food, about the healthcare services, and what they can access and what they cannot access. If there's limited mobility, they're not going to go to another neighborhood. They don't have that opportunity, right? And so again, we haven't even gotten to the health outcomes, but oftentimes a decision about my health is the last thing on my mind, right? And what we hear from our clients, from the community that we serve, that if I have to make a choice about food, about housing, and then about health, health is going to be the last thing on my mind, right? Choosing to purchase the medications, going to see the doctor, don't have the time for that, right? Now, the other conversation that we often have, we talk about stress, but when we talk about stress and race, right, there's a difference, right? We've seen some articles that come out that talk about the allostatic load and how we can measure certain hormones to see that, yes, stress is higher in people of color. But what has always been missing in that conversation is how racism has played in the increase in those markers, right? And that has led to the amount of stress. And then we can talk about health outcomes, right? Heart disease, diabetes, obesity. So that's the connection, right? When we talk about at an interpersonal level in research. So there was a recent series that Lancet just published. It was a 5-part series. And one of the articles that was in there was actually a publication that was authored by a number of people within our Center for Health Equity, including Dr. Nancy Krieger at Harvard University, and including Dr. Bassett. She was the lead author. And this was a framing around structural racism and health inequities. So really beginning to frame the work that we're doing out of the Department of Health, and also highlighting and elevating some of the work that's happening at the Boston Public Health Department. Also, this is happening in Oakland, Alameda County. They've been doing a lot of work. Kings County and Seattle, they also have been doing a lot of work about framing health equity, doing trainings and professional development to understand how structural racism has played into the work that they're doing, but then also what do we have to do within our own institution, right? And so understanding what's happening with poverty, people of color are far more likely to live in poverty. Health, people of color are far more likely to report a higher rates of fear or poorly self-reported health status. And then going into the work and the living conditions. So this is an attempt for us to see, going back to that framework that I showed about 5 slides ago, to see what we're doing more upstream, right? So getting to the living conditions, but then also understanding what's our ability to pull levers around that institutional power. And then even further than that, what's our work around the class, the race, and the other gender equities, right? And so we've been doing a lot of work, not just around race and ethnicity, but we also have been doing work around gender justice as well, and reproductive justice, right? And so, again, this conversation of equity doesn't just limit to how we are engaging this conversation around people of color. We're seeing inequities in multiple groups, right? And so what does that work for us look like? So jumping into what we're doing now, right? That was a framing. That's a lot of things that we talk about. So what are we doing now? So this was a call to action that came from now Commissioner Mary T. Bassett in 2014, right after the report came out that the police officer in Staten Island was going to be set free for the murder of Eric Garner. And she provided this quote in the email to 6,600 employees at the health department. This went to everyone, not just senior leadership. She sent this email out. And there was obviously really a lot of disappointment among staff after that ruling came out. And she talked about not just only inequities in health are unfair, but we've, as a city, we see the unequal and avoidable treatment that we see in many neighborhoods. Because of the segregation in New York City, it's no surprise that a lot of things that we are seeing, a lot of the rulings that we're seeing, there's no surprise, and that leads to the disparities and inequities that we have. And so the work that we do within the Center for Health Equity is not just around health. It's really making sure that we are looking at what our role is around those living conditions, and even more upstream, what our role is around institutional power. And so this is the mission and values of the Center for Health Equity, which I am a part of. The Brooklyn Neighborhood Health Action Center now sits under, and also the Harlem and the work that we do in the South Bronx. And as I showed you in those maps, those are the neighborhoods that light up the most. And these are also the values that we have. And I'm always clear about making sure that folks see both our mission and our values, because these are the foundations which we need to stand on as an agency, right? And so the approaches that we've taken within the Center for Health Equity, many of them are not new, but the one that I will make sure to highlight is the reform process that is priority number 1 for the agency. It's how we become an anti-racist organization, and that work is not easy. That work is taking time, but the outcome is to make sure that all employees, we're not just talking about senior level staff, directors, we're talking about all 6,600 or however many people that will come to work for the health department, that they have been involved in this process around becoming an anti-racist organization, taking professional development training, and be a part of this process, this internal reform process. And so this is 3 years, 4 years, 5 years that the agency has set out as a strategic plan to begin to understand what has been the institutional culture and what are the organizational developments that we need to do to make sure that staff are connected to this work, right? And then they will see this in their work, whether you are doing emergency management, whether you're doing communicable disease around the Bureau of HIV, or you're doing work in chronic disease, or you're doing work within the Center for Health Equity. Everyone is connected to it. And so this is a process that all divisions are currently underway doing. The second priority is around how we name injustices and make them more visible through social media, through our reports, the things that we do, the work that we do within key neighborhoods. And then the last two is much newer for us as a center, as an agency. One is thinking about health equity in all planning. And so this is this role that who else needs to be in the conversation? Who are those that need to be talking about health? How are we coordinating with other city agencies, other institutions, other nonprofits, and community-based organizations? So this health equity in all planning is our ability to lift up all voices, make them equitable in how we see what our recommendations and our approaches are, and then ultimately how we amplify community power. Right? So the first priority, first approach is, again, going back to reform and becoming an anti-racist organization. So this is the work that is happening within our institution. So one, how do we normalize the conversation first, right? Again, and that's what I began to talk to you about before. How are we beginning to have conversations with everyone, right? Top to bottom, bottom to top. And how we operationalize that, we're using certain tools, we're working with certain agencies. We've already have trainings as an assistant commissioner, our deputy commissioner, our commissioners, the first deputy commissioner, all talking about these tools. So us working with the Center for Social Inclusion, right, is one of the agencies. I'm also working with Prevention Institute. And so there are organizations that have certain frameworks that have been very helpful for us. And then the conversation, you know how trainings are. You sit there for a full day, 2 days, you go back doing that work. But the conversation is, how do we make this more of an everyday practice? And then how do we assess what we're being trained around, right? And so understanding what our data and our metrics are to know how we're improving the way that we do our work. And so the organizing work is also our external facing work, right? We partner with a lot of people. We work with other city agencies. So there's an opportunity for us to really push our other sister city agencies to say, this is our approach, but we need you also at this table. So when you show up in Brownsville, then you're not coming with that traditional approach, you're just telling people what you're going to do. It's how are you co-creating and co-developing your plan with the community, right? But also ridding yourself of some of those older mindsets about those stereotypes that have been baked into the work that you've been doing. So naming our injustices, and I'm not going to spend too much time on the data because I think a lot of people have seen the community health profiles, but I was asked to elevate some of the health data that we do have. But I'm also just showing you that some of the other work that we do, some of our reports, so lifting up voices within the neighborhood, our epic data briefs, which are more academic in nature, so there's just more data. They're much more shorter, about 3 pages, and they're really showing some of the data. But what we try to do with our data briefs is again, to this health equity piece, is making sure that we're lifting up some of the neighborhood context, right? And so it's not just showing you the numbers, but it's also elevating, well, what are some of the factors within the neighborhood, the environmental conditions that have led to those disparities, right? And then also non-traditional platforms, right? So Huffington Post, BK Reader, so other web-based platforms that we can get the information out to the general public. So this is our approach of making sure that we are elevating and naming those injustices. So the community health profiles, really quick, and I don't have all the data for all 18 community districts here in Brooklyn, but I am going to elevate about 5 of them. Again, this is many of the neighborhoods that we work in now. But the difference for the community health profile, so this one is much different than the 2012 version. In 2015, Commissioner Bassett wanted to make a greater emphasis on equity and social determinants, and so that's where you see some of those other indicators. But then we switched them from the United Hospital Fund area, which really clustered certain zip codes, and we based them on community districts. So this allows for community residents within certain community districts, whether you live in Community District 8, 2, 3, 4, 16, to be able to talk to your elected official and say, well, what are we doing around this indicator? What are we doing around this? And so that was the switch in 2015. Here I'm just showing you the total population for 5 of the neighborhoods that we particularly work in. Do not feel slighted that I did not list East Flatbush, but we do partner with a lot of organizations within East Flatbush. But these are the 5 neighborhoods, and I would say really the top, the Bedford-Stuyvesant, Bushwick, East New York, and Brownsville are the ones we primarily target. But when you add up the total population of these 5 neighborhoods, it's about 25% of the Brooklyn population. And so the other way to look at that is 25% of the Brooklyn population bears the heaviest burden of disease, right? So that's the narrative, right? And not just because people are making bad choices, but again, going back to the indicators, right? And what they're living through, what are the conditions, what are the environmental conditions in those neighborhoods, right? So this is just a breakdown of who's in those neighborhoods based on race and ethnicity. So you'll see that many of them are people of color in all 5 of the districts. So I showed you infant mortality for all of New York. Again, you'll see that Brooklyn overall is 3.9. New York City is actually, this was 2012 data, so this is 4.7, but it's actually going down. Since then, we have more up-to-date data. But you'll see that when you compare them to the neighborhoods that I spoke about before, the Upper East Side is ranked 59. So they actually, what's ever in green is also the best performing neighborhood, just so you know. And then when you'll see that Brownsville is ranked 4th, East New York is ranked 5th as far as having the highest infant mortality rate. Anybody know who's number 1? I'm sorry? South Bronx, not in the Bronx. It's in Queens. Queens, Jamaica. Jamaica, who's at that? Jamaica, yeah. Oh, because I said it was in Queens, yeah, I just went there. Yes, it is Jamaica. Jamaica has the highest, is that I think it's at 8.1, 8.2 as far as infant mortality rate.
Are you the first year of life or?
First year.
First year.
Yep. So some of the other indicators that we look at is poverty, rent burden. Are people familiar with rent burden and what that means? I gotta wrap up. Rent burden. So rent burden is really looking at how many residents within that neighborhood are spending 30% or more of their wages on living conditions, right? And so this is just showing that you'll see that 55%, more than 50% and higher are using their salary on living wages. I mean, just on rent, excuse me. Poverty, as you know, is just for the federal poverty line and the unemployment rate. Adult education, just highest level of education attained by adults 25 years and older within that neighborhood. And so one of the things that I like to point out is that you'll see that more than 70% of people within these neighborhoods at least have a high school degree or higher. So this idea that people just need to get educated, right, doesn't really address the issue, right? And so that's the point that I like to raise with this map, this graph here. That it's not always about education. Like even when you have your degree, you can have college, you can have higher, that your neighborhood conditions doesn't change when you automatically get educated, right? And so it's this narrative that we really need to change. And what does that mean for folks to be educated within their neighborhoods, right? So I'm going to just breeze through, but just know that the community health profiles are on our website for all 59 community districts. For New York City, there are 18 here in Brooklyn, and then you can see them for your neighborhoods. Right? But this is another thing I showed earlier, elementary school absenteeism. So just looking at the percent of students who are missing school 20 or more days, and then you'll see, for Bedford-Stuyvesant, they're ranked 6, so 6 out of 59, not just 6 out of 18, which is pretty high. We also look at jail incarceration rate. So this is the first time that a community health profile for New York City has included this indicator, and then you'll see that many of the neighborhoods are showing up much higher. So Brownsville is ranked 2nd out of 59. It's having one of the highest jail incarceration rate. So again, if people are locked up, then what's their ability to be present and advocate for what's needed in their neighborhoods? And then also the questions about practices. You'll see this is another indicator that I showed on the map. So I was just showing you the totality for New York City, and here I'm showing at the neighborhood level. And so, when I say that, these things are lighting up for all of the neighborhoods, then you'll see, see why. So ranked 8th for Bedford-Stuyvesant, 13th, 1st for Brownsville. So Brownsville is number 1 out of 59, for having the highest non-fatal assault hospitalization rate for the city. All right. Childhood asthma. This is nothing new, so I'm going to just breeze through this one. So a lot of the work that we're doing now within our key neighborhoods is really developing these new neighborhood health action centers. And so we previously were called district public health offices. You know, we have one here in Brooklyn since 2013, and then, 2003. Sorry about that, 2003. And then we also have one in East Harlem and also in the South Bronx. And so this is an opportunity now for us to do things differently. Before it was just health departments were doing work, we have programming, we have funding, and we're just trying to push those things along. This is an opportunity to take our buildings and really offer them to community organizations within our neighborhoods. So our Brownsville building, we've also invited the FQHC, Brownsville Multi-Service Center, so they are expanding. They were previously in the building. We also have Brooklyn Perinatal Network, who's been in the neighborhood for more than 30 years. They are now taking up space. So now it's not just what's the Department of Health doing, it's really taking these underutilized buildings and inviting community to use them. We've also created community space within the building, so there's a community lactation room. We're gonna have a community multi-purpose room, so you can do exercise class. You can also hold trainings or conversations. We're also offering to our community boards to use the space. So this is a great opportunity to really interact with community, but also to be in formal partnership with them, right? And that's some of the things that we've been talking to with other partners, even with SUNY Downstate, to really figure out what the formal partnership could be with your institution. So we're opening now, we just opened 3, Brownsville, Tremont, East Harlem. East Harlem just held their open house, and Tremont just held their open house for the last 2 weeks. Brownsville will be held in June, right? And so these are some of the services that we're gonna have in the building. That's the East Harlem building, so that's not how our building looks. I talked about health equity and all planning as an approach. This is still being formalized about how we do our work. Again, it's not just about the health indicators, but it's also understanding how health interconnects with housing, discrimination, food security, stable income and job security, so workforce development, thinking about environmental quality, so air pollution, what are the resiliency things that we can do, right? And so we've been talking a lot with city planning, housing preservation and development, to think about what are the opportunities that we can really begin to understand and address, things like heat maps. And so climate change has been a real conversation, even within equity, which has been really fascinating. And then some of the things that we're doing around amplifying community power. So one example that I'll mention is that we did not lead this process. This was actually led by Bed-Stuy Restoration, which was actually funded and developed back in '66, so during the Johnson administration. And they've been Community Development Corp for quite some time doing that work, being one of the beacons around that model that was started by the Johnson administration. And so they just took on more of a stronger role around health. They've been doing work around farmers markets, and then they got really integrated into the bike share work, partnering with DOT, so transportation, partnering with parks, partnering with Motivate, who is the company that actually implements the city bike docking stations around the city. And so in 2015 and 16, there was an expansion of the bike share work into Bed-Stuy, or the eastern side. And so what is that perception by residents who've been long residents within Bed-Stuy to say, is this for us or is this for the new residents, right? Not for us. And so there's been a lot of pushback, particularly at the community board. If you were there, you've seen a lot of the spirited conversation. And so there was a lot of work that we had to do with community, right? And this is the conversation that we do, what do we do in partnership with community, not just putting the bikes there, put the bikes there, they will come, that doesn't happen. Build parks, they will come, that doesn't happen, right? It's how we do it together. And how do we ensure that community sees this as something that they want to roll out. And so this was a great process, and this was a report that was just published in March by Bed-Stuy Restoration. We were in partnership with them, and I will say that it's been a really great process. I would say that this has been one of the collective impact models that have really been successful for Brooklyn. To have the amount of people, NYCHA's at this table, and so you folks who do City Bike or know about the pricing model and like the monthly membership. So for NYCHA residents, it's $5 a month for a membership, as opposed to anyone else who doesn't live in NYCHA. It's like, I think $25 a month, I forget. But just having that equity conversation, right? Those equity measures are there. right? And that's been a lot of the conversation, like really pushing other city agencies to see what their role is in making sure that it's accessible and affordable for others. So I do think it was a really good process. Even parks, because we want to make sure that folks are utilizing the open space, how we activate the open space, farmers markets, cultural events, and some things like that. So parks was there and really hearing what residents wanted. And that's the impact. That's how you have lasting impact, because now it's not an agency driving this conversation. You have community driving this conversation. And so we're continuing to work with them, and we show up, but we understand that our role is more supportive. Right? So I'm really lifting up restoration, not us. So lastly, in that article by Dr. Bassett and Dr. Bassett and others, some of the things that she lifts up about training the generation of the health professionals that are coming down the line. And so this idea that what is the pedagogy around race and racism and health, and really integrating that into your curriculum, right, is so necessary. And it's been pushed by students, because they've been moved and really inspired by what's been happening around this Black Lives Matter, and really having conversations. Folks may remember that in the New England Journal of Medicine, Dr. Bassett had wrote an article, a perspective around hashtag Black Lives Matter, really talking about and highlighting how students across the country participated in student die-ins to push this conversation around what's our role as health professionals in pushing and addressing racism and inequality within this country. And so I think it does fall on institutions to make sure that it's not just a 1 hour conversation, it's not a 2 hour conversation, but it's a course, but it's integrated throughout our courses. And we're making sure that we are having some discourse with our students and training them that before they become physicians or nurses, before they become public health professionals, that they understand that their framework has to be in line with health equity, right? And what does that mean for them? And so this idea about institutions taking on that pedagogy around racism and health. The other thing that I spoke more about around institutional structure and organizational culture is the commitment on the institution to really understand what its role to educate its current faculty, its staff, around implicit bias, even around explicit bias, and what happens within our organization. So taking on that role, and we've been doing a lot internally, and happy to share some of the resources that we've used, some of the tools that we've been using. And so, now that you have a new president, a Morehouse man, I think that this is a great time to have that conversation with your new president to really say, what's going to be our process internally to make sure that we're not only having the conversation, but we're elevating leadership. It's not just enough to say that we have a Black president, right? There's more to it. There's much more to it. And how do we make sure that everyone is on the same page? What's the mission? What are the values? What is our commitment to the community? And that has to be bought in by everyone. And so that ties into professional training for clinical and public health professionals. Your physicians, your health professionals, or your external facing staff, and they're talking to the community all the time. What they say to community matters, right? And how they speak to them. And if your professionals do not know that the community-based resources are available, simple things like what are integrated pest management, your physicians should know that, right? The water leaks, the pest management. How are we making sure that professionals have that information? They don't see themselves as just medication service delivery, but it's more about resources and making those connections. So, and ultimately the collective impact and community engagement, I know that that's a conversation, speaking with Dr. Lewis and others here about what our role is as a health department in partnership with SUNY and doing collective impact, community engagement. And so looking forward to more of those conversations, but there is a commitment. I know that's in your mission as an institution. But what does that really look like? It's not always just showing up. I think that there's more to it about collective impact and who's at the table with you in planning and things of that nature. So this is just, folks who know me, and last time I was here, I was speaking about this issue around Black men in medicine and really making sure that we are calling out that conversation. And there is work from an equity standpoint of why we're still seeing a decline on the number of men in medical schools. And I was in DC because of the organization that I co-founded called Young Doctors DC, to really work with young men in Southeast DC to really get them connected to pipeline programs. And so we've been working with AAMC on this work, and it was very successful. This is our first cohort. We had 6 young men from Southeast DC, and we're really looking to expand and hopefully maybe come to New York, bring the same model. So maybe this is another partnership for SUNY Downstate. But that is all for me, and I thank you for the time.
Thank you very much to Dr. Easterling for taking time out of his busy schedule. And basically, why are we here? Because we are SUNY Downstate, and we do have a mission of academic excellence, patient care, and research. And in order to do that, we have to understand the underlying roots of health disparity. So how did we start this? So this started with 4 medical students approaching me individually. Rebecca, if you're here, stand up. Rebecca, Alex, I don't think Defke and Tajana are here, but they approached me individually. We need to do something. And then I said, okay, hold on a minute. Call doctor. We got to do something, right? And we said, okay, all right. And then we started calling people, Dr. Sweeney, Dr. LaRosa, Dr. Lewis, Dr. Kaplan. And then we realized we had a tremendous resource in Dr. Salafu and Dr. Stracker through the Brooklyn Health Disparity Center and Arthur Ashe. So we all came together to see what is it that we can do to advance leadership in health equity. And Dr. Easterling is our first speaker of a series of lectures that we're going to have. We're going to have one, I believe, with Dr. Dill in the summer, looking on violence. Actually, on Friday, we did have a discussion on allostatic load, microaggression, and intersectionality. And that was very well attended. So we did spark the dialogue, but this would not have happened, and then I'm gonna stop talking and give you time for questions, without offices coming together. So Brooklyn Health Disparities, Arthur Ashe Institute, the Office of Faculty Development with Anne Marie Cullen and Karen Thomas, Diversity, Education, and Research with Shamika Bowman, Magda Alianson, Dr. Magda Alianson, and Anika Daniels-Asazi, and of course, Dr. Joseph through the School of Public Health, Dr. Alan Lewis and CHIRP. I spoke with Dr. Daisy Ruiz. Cruz Richmond, Dr. Daisy Cruz Richmond from nursing. So this was really a collective impact approach to addressing our role as an academic health center in SUNY Brooklyn. So do you have time for questions?
Yeah,
so
sure,
there's
sure.
lunch. Please eat, drink. Otherwise we have to throw it away. So there are questions.
Okay.
If you have any questions.
Sure.
A lot of times, I know just in my neighborhood, if I'm making complaints about noise, the response that I get from police officers is often, oh, well, you're in that neighborhood, what do you expect?
Okay.
So it's this whole notion of when you're in a neighborhood with a lot of people of color, you should expect it to be noisy. And it sometimes leads to other things where it can lead to drug use, public urination, just the crowding of people in an area where it starts to become a party at night.
Yeah, well.
And no one wants to deal with that. And I know that primarily happens in neighborhoods of people of color.
Right.
Another issue that I noticed, and I'm not sure if this is specific to communities of color, but also the new traffic laws. You have the floating parking, the bus lanes, the bike lanes,
Yep.
and all the cars are being shoved into like 1 to 2 lanes of the street. And supposedly it's supposed to help us with asthma, but if you have more cars shoved in the middle of the street, idling longer because there's less space for them to move, I would think that would increase the asthma rates in certain areas. So.
Yeah. So the change around the traffic law, so we're often doing that at the community board. We're having that conversation, I should say. So for instance, particularly around the bike lanes, the expansion of the bike lanes in Brownsville, East New York, and even in Bed-Stuy. So that was in concert with community to really talk to, all right, what are the benefits? What are the challenges? What are the risks? And even so, DOT provided a lot of context around, addressing idling laws and also addressing the pollution. So air pollution was also addressed. And I'm not the expert on that, but I will say that we did make some changes based on the feedback that we got from that conversation with community. So, I think that it's going to have to be a lot more dialogue and conversation with DOT to say, all right, what's helpful and what's not, and what are the challenges and risks. I mean, I think, the more that folks are hearing about air pollution, is that really true? Because I'm not really sure, right? Like, does air pollution get worse because we're compacting folks into 1 lane, 2 lanes, or because we have 3 lanes? It sounds like, it's logical, because the more the cars are idling there, then they're just sitting there parked or sitting there at a stop, the stop, that does increase air pollution, but I'm not sure, right? And so I think that's some of the things that we need to do to really provide some of that data, and then people are making an informed decision. The noise pollution, I was just going to say that I have no idea what has changed or what's not, because we usually don't respond to that. But I think that needs to be brought up at the community board, and it usually does. I usually hear that that's where that conversation comes up, particularly in the summer. So yeah, I think that's the best space.
They have like 8 hours to respond. And a lot of times, I mean, the stress that it causes for people to get up in the morning and go to work, I'm sure that has an impact on their health as well.
Sure, yeah, no, absolutely. Yeah, and when it's brought up, I don't think it's brought up in a way that it, impact, like what is the context and stress, what's the context and the health outcomes, and I think it's more just convenience and the inconvenience that it causes people, right? So having that context.
Before we go on, I do want to thank Dr. Gwynn for coming and starting us out. Dr. Riley's office, Dr. Gwynn, they've been extremely supportive. We've met with them about the importance of doing this, and also Dr. Chris Roman from the graduate school. So we're also including a basic science component to address some of the stuff you did with allostatic load. So just wanted to thank both of you. If there's anyone else I forgot, please charge it to my head. Thank you.
I want to thank you for this presentation. You said something earlier that really stays with me, because when you started to relate the situation of slavery and health conditions, and Paul Mooney, a comedian, once said, he said, where were all these conditions during slavery? Because the same impact these institutions see people of color as being stronger and more durable when it comes to all of these environmental impacts, prevalent diseases, while the slave masters were getting treated for the same things that were impacting the chattel, the slaves. It was overlooked because that's property. They can endure. They probably have genetic factors that will help them to overcome whatever conditions they're in. So I'm saying there must be more sensitivity of how institutions perceive their patients of color.
Yeah, no, absolutely. And it's interesting because I was looking at something that Du Bois had written, and this wasn't Souls of Black Folk, but this was actually an earlier epidemiological study that he'd done in Philly. And he began to identify some of the biological markers that you looked at during slavery, and he brought it to present time at that time. And I think it was like 1906 when he wrote that study. And that was like the first form of really linking enslavement of Africans and looking at those biological markers and talking about, this notion around inferiority and superiority and how we, how our body systems are reacting to stress. And so, and I think that was really like the first conversation around how we present equity, because he looked at it at a neighborhood level. He was looking at South Philly and he was saying, if you look at this cluster of people who live in these neighborhoods and you see in this zone, and I forget the streets, but you could see the worst health indicators in this area of Philly. And it was just really interesting how he linked a lot of that information to those biological markers that we didn't really take into account. I don't know if they took that into account, but it was, that conversation again is not new. It's just bringing it to light, bringing it into the discourse of, our academic conversations, right? So no, absolutely, yeah.
I wondered if there's going to be a look at how neighborhoods like Bed-Stuy improve as new populations come in. They're going to improve.
Yes.
Going to improve.
We are. Sorry. Go ahead.
Impact on, like you probably wind up moving your office because your office is in an area that's changing, and so the way in which our elected officials begin to move in resources without anybody having to fight for it. I mean, how do people get to hold on to their properties? How do people, that whole discussion, because that neighborhood is changing, changed.
Yeah, no, absolutely. So we have not, and so we haven't looked at the displacement and gentrification, the impact of health on gentrification and displacement, particularly within Bed-Stuy. Brownsville and East New York, I think is homogeneous enough to say that when you look at those indicators, like those are people who've been there for generations. But when we look at Bed-Stuy, like what's the changes over time? And this is 2014 data, so this is pretty recent to say that we're still having some indicators that are some of the worst in Bed-Stuy, even with gentrification, which has been over the last 10 years. So I think we can still safely say that our work is in the neighborhoods that we're seeing the displacement, because what we now need to do is just pull that out and tease that out a little bit more. The article that I mentioned with Dr. Krieger, one of the models, methodological approach that she's been talking about is this thing called ICE. So really looking at populations within neighborhoods to see where there are clusters and where there are sort of heating zones of like high rates of diabetes, high rates of jail incarceration rates. So we're having that conversation. We haven't gotten there yet, but that is a framework that we're very clear that we need to begin to be able to discern and distinguish what neighborhoods, who has access to what, mobility, right, being able to go to other neighborhoods and access other resources, and who has limited mobility, who's not able to access other resources because they're within those neighborhoods. And I think the other thing that changes is as people are moving in with higher income and with higher privilege, the change in that neighborhood, right? So what stores come in, what businesses come in? Do we see changes in health outcomes so far? And so this thing around parks and the city bike, the whole first conversation was, would this have happened if we didn't see displacement and gentrification in Bed-Stuy, right? And so that was a lot of back and forth that we, that the DOT had to explain why this even happened in the first place. And so the conversation started with, well, this expansion of bike share was happening without gentrification or not. Right? And we're starting to see it already, like it's going up to Harlem. So it's going up to 110th Street and then even further. And then it's also, is actually expanding beyond Bed-Stuy as well. So there's a lot that we have to do. So you're absolutely right. And we don't have all the answers. And so we've been working with other, even Oakland. Oakland has seen some serious gentrification out there. And so we've been trying to understand how we need to look at it as well. We can learn. Yep. Dr. Kaplan.
Excuse me a second. I'm sorry. I got to run off to another meeting, but I want to, take this moment to say thank you to Dr. Easterling on behalf of the president. Obviously, in his enthusiasm for this work and his knowledge, more importantly, of this work, it's evident. One thing I was thinking about as he talked, I'm a medical sociologist by training. So some of the things I'm thinking about is, as he's explaining is, how does a sociologist or how does a medical sociologist work with someone like Dr. Easterling? Because a lot of what we do it in silo, as we know, which is obviously problematic. But I'm thinking, I'm thinking about social ecological theory. I'm thinking about sociobiology, all of these things that he talked about that is put in a different language because of a different discipline. But again, I'm thinking working together. So I'm hoping we're all thinking about our respective disciplines, psychologists, etc., thinking about our respective disciplines and how we collaborate, how we work collectively to address some of these social inequities and to push forward social equality. So again, I just want us to think about that. One other thing I thought about is, how many races are there? How many races are there? That is not biblical. It's not biblical. It's not biblical. But I'm thinking about his examples that he brought up. How many races in terms of the creation of race? I'm a sociologist. Keep that in mind. So how many races are there? No. Keep in mind, race is a social construction. So how many races are there? I'm sorry? There are two. Black and white. Hence the idea that race is a social construction. There was only black created to separate in terms of black and white. So all of the other stuff that we talk about, those are ethnic groups. They're ethnic groups. So again, I'm thinking about all of this stuff that he's bringing about. It's like, wow, if we all work as a collective unit, we can better understand this stuff. We can better address these things. So again, I want us to think about that again and offer my thanks to Dr. Easterling, to Dr. Bowden Foster, Dr. Joseph, and everyone else who had a hand in bringing this together. Again, this is important work. I hope it will continue. And again, on behalf of Dr. Riley, thank you. Thank you guys for taking time out of your schedules, and I'll see you next time. I spoke too soon.
There was one other, Dr. Copeland, you had a question?
I'm just wondering if you know of work that's been done, I don't know, looking back and forward and projecting with sociologists and all of them, or whoever else, about whether you can start gentrifying a neighborhood, make the neighborhood starts changing. I mean, this is happening all over the place in New York City, and whether you can stop that, or does it just stop on its own so that you get left with what people might view as an optimal, nice, diverse neighborhood with lots of different income levels and different types of housing and food,
Where do you see that?
and we could ban the Starbucks, I don't know, but and bring in some decent coffee that doesn't cost a fortune.
Yes.
That's a joke. But can that happen?
Yeah. I have not seen that, and I haven't seen, and I think Dr. Krieger has been really good at looking at the differences in neighborhoods. So, one, looking at the distinctions in race within neighborhoods, and also looking at how the demographics have changed over time and what has been the positive and the negatives. I think Dr. Krieger has some really good research. Now, the problem with that is that it has been more sort of natural and organic, and like how that process has happened, enforced, but not in a way that it's been sort of methodological, like you're talking. Like, can we do it in a way that it becomes positive, and we know where the stopping point is?
We study a community somewhere where, I don't know, it partially changed, but it didn't change completely. No.
Yeah. I don't know, and I don't know which would be like sort of a demonstration neighborhood, right? To really look at.
Do it, to me, and this is the understanding I have. Once the real estate property, folks determine this area is going, it's going.
Yeah.
You see Starbucks, it's open.
Yeah.
I mean, Starbucks is.
It's the key, right? It's the key.
Yeah, that's why I brought it up.
But this is sort of a related question.
Right.
But I consider gentrification really a reverse migration.
Mm-hmm.
So, has anyone looked at the health of the people that are being displaced?
Yeah.
Look at the people who are being displaced from those neighborhoods and where they're going. Oh yeah. I'm not sure. No, I haven't seen that type of research. I don't know if others have. But go ahead.
I'd like to say that I do a lot of working with medical students to do health outreach presentations and such. And just as you said, health might be at the lower end of priority, but there's also a situation of people have no control over their environment. Sometimes if they're homeless, they're moved from place to place.
Right.
And one of the factors is continuity. I think we all love to know that we go to the same doctor and are able to have a history to relate. Whereas if you're someone who is transitional like that, you go from place to place and you're meeting with someone who has no idea of what your health history is, or even how to treat you as what you've been through.
Yeah.
How was your office sort of collaborating with many of these, like ACS and many of the Department of Homeless Service?
Yeah. So this thing about connecting to clinical services and access to services. It's such an important conversation, and I think it's so needed. But for us, we've sort of taken a back step and say, all right, access to service, a lot of people are doing that, right? There's a lot of hands, and for us, it's more upstream and saying, all right, how do we even change the neighborhood? So whoever lives in that environment, it would afford them the best health opportunity. And so, so for ACS, HRA, I mean, many of the external facing city agencies that are providing resources and services to families and particularly to vulnerable populations, our conversation with them has been around making sure that we're coordinated. So we work with the Department of Probation. So I don't know if folks know, but they have borough-based buildings, right? And they have it in Brownsville, Bed-Stuy, they're in the South Bronx, which I didn't know. I mean, I thought that was interesting that they have service delivery buildings within neighborhoods. And they're providing services to populations who particularly live in those neighborhoods. Now, folks can see that as they're only servicing individuals who have some type of adjudication or some issue that they're just been addressed by the judicial system. But actually, they've changed their format and they are servicing everyone. Anyone that walks in their building can actually access their services. And the problem is communities don't know. Like I didn't even know that they were there and they're around the corner from us. ACS, I think, so one, I think is how do we erase the stigma around these organizations, right? And so it becomes less about, criminalizing individuals, right? Or marginalizing them and just saying, all right, well, because you have to work with us, then there's sort of a black cloud around you, right? It's really saying that we're here for this community because we see that this is the indicator and we see that many of them are going to jail or they're, and so what's our role? To be more prevention, to work more upstream, to be more coordinated, right? And that's the push that we've been making with ACS, HRA, so many other city agencies, and talking with them and working with them. So I think that's the framework.
So my thought, because I don't know the detail, is that perhaps one of the things that might be added to the Neighborhood Action Center is some kind of financial, I'm not sure how to frame it, but someplace where people can go and they can work on those things that help them to sustain themselves in this changing neighborhood. Sure. And I don't know if that's been considered. I mean, that's where the place you spoke of, Bed-Stuy.
Restoration.
Yes, Restoration started
Yep,
that.
that's right.
And maybe in each of the centers so that people who have at least begun to try to have a stake in something can maintain their stake. I mean,
absolutely.
That's a big problem.
Yeah, absolutely right. I mean, and so we don't want to see, we do not see our building as a one size fits all for each neighborhood, right? So I do think that the conversation around workforce development is something that we've been talking about and we have considered for our buildings. But now that we know that DOP has a lot of workforce development within their buildings and it's open to the community, it's more saying, all right, what can we do in partnership with probations? It's more saying in partnership with, DYCD, so the Division of Youth and Children's and Families Department. Like there's a lot of opportunities to partner with other city agencies, other organizations, restoration, because they have those workforce development. We see ourselves maybe as a satellite, maybe if you want to extend or expand the services that you're offering because we have the space. But I mean, the conversation around, how do we lift up, promote economic development, job opportunities, I mean, that is absolutely on our minds as well. Yeah.
Thank you for this presentation very much. So I think one profound point, at least for me, was this concept of trying to get better metrics on inequity, and not just the ones that one would normally think about for health, but like rental inequality, right? And so what made me think also is like, if you have elevated child illness, that's burdensome on a family, that's burdensome on a household. There's got to be like economic metrics for that, like how many days missing, you can't pay for a babysitter, there's no daycare, something like that. Somebody around you has to absorb that burden of illness. Yeah. So I don't know what the Department of Health thinks about that, what metrics there are around that.
Yeah, so it's interesting. So we do have our Division of Family and Child Health. So even though it's not within our division, we do work with our DFCA, so Family and Child Health, because they actually work with our environmental health, a lot of different divisions around what we call the inspection and certification of home daycare centers. So we work with child care centers and home, and because we do, just like we do food restaurants, we do child care centers to do inspection. And so there's an opportunity for us to begin to collect that data. We didn't collect it before. And so that's one of the equity measures to really look at, like how many days people are not bringing them to daycare center. Why? What are the reasons that they're missing? What are some of the other social issues that need to be flagged for us? So we're beginning to think about what those measures are. And I was even talking about like even environmental health now, or even looking at things like, so based on certain neighborhoods, we know that if there was a flooding here, or if there was a heat zone here, or we knew that there were a number of people who died from heat strokes, we wouldn't be able to staff certain neighborhoods just because of the way that our staff are situated throughout certain neighborhoods. So like we looked at, there was a map and we show like where staff live at, who work at the health department. And then if we look at senior leadership, so many of our senior leadership staff do not live in Bed-Stuy, don't live in South Bronx, they don't live in East and Central Harlem. And these are the staff that are particularly responsible for responding to emergency management. And so what we're now thinking about is, all right, so what do we need to do? So obviously, one, we need to diversify leadership, right? Because now we know that they're coming from those neighborhoods. And then we need to think about how do we staff those neighborhoods that in the case of an emergency, the city needs to respond. The point of dispensing, which we know are vulnerable populations, how do we address that? So again, this is in every division. We're beginning to implement those equity measures that we, just hasn't come up. I mean, the Ebola issue has highlighted a deficiency for us because we needed to respond to certain neighborhoods based on, folks who were living, who were originating from certain countries. But you're raising some really good points, and we've already considered some, but in some we haven't. Yeah. So this is good. That's another hand. Lena?
I just was saying that this is just amazing, so progressive, so meaningful, the work that you described that the Department of Health is doing.
Yep.
And I'm not going to keep us, but we talked about gentrification. Of course, that was in my head as soon as you started showing maps in different areas where people live and where they don't, where they haven't been allowed to live and where they have been allowed to live. And we know that in Brooklyn, everyone is moving into every one of those neighborhoods that people traditionally were not allowed to live in. And I started to go to community board meetings and find out that these plans are done 10 years in advance.
Yeah.
Because every 10 years they have to do a 10-year plan. To find out that this neighborhood here is in the midst of its 10 years.
Right.
And the things that they plan for this very neighborhood are the same things that you've seen in Bed-Stuy. And even Park Slope. Lots of folks used to not live in Fort Greene or Park Slope. That is happening here. It was planned 10 years ago. So the housing stock and everyone moving in, and this hospital is actually at the precipice. If we plan now to cover things like open spaces, places where folks can work out, like you said, bringing in healthy food options, all these things, we can actually plan it now and not miss that balance that Dr. Kaplan was talking about. That we're not too late to mitigate the turning of this neighborhood completely into a place that's not on this map for the things that. So I would love to know that you're working with the hospital in letting. This was very good in informing the decisions that will be made for the next 10 years of Downstate.
You're absolutely right. I think that this is such a crucial time to jump into these conversations that are happening around planning, not just around housing. Folks may know that just a month ago, the governor came to Medgar-Evers and talked about $1.4 billion investment that's going into North and Central Brooklyn. There are 10 assembly districts. You are in one of them that is receiving the funds. And supposedly, the process is supposed to allow for community to recommend and advise on the strategic planning. I think SUNY Downstate should be a part of that. And, I'm not engaged with Nick Perry and other assembly members who are in this area, who cover this area. But I think because you have like a Brooklyn Health Disparity Center, and you know what are some of the reports that have come out, they need that information. So they are not having conversations on things that have already been discussed 10 years ago. And because there's so many silos, assembly members are trying to hurry up and do their own plan, and there's just not a lot of cross-coordination because the governor, don't record this, the governor and the mayor are just not, there's a political issue there. And so city agencies are not even at that table, right? And so there are opportunities. Right, there are opportunities for us to get out of our traditional role of just providing clinical services, providing public health services, providing housing services, and to think, all right, what is my role in providing a healthier neighborhood, right? That's a totally different conversation. And to do that, we have to create a table that would support that conversation, that dialogue and discourse. But I would definitely, push President Riley or whoever has those elected official connections to say, how do you think SUNY Downstate can support the planning that the governor is doing for our district, or at least the communities that we know our patients are coming from, right? And this is, we have data on, patient, utilization, or emergency room utilization, high utilizers. I mean, that information is so key for the advisory council. And unfortunately, I don't have that leverage, unfortunately. So I would do it, but that's at the state level. I'm at the city level. So,
Okay, folks,
but just to put that there.
I think we should give Dr. Easterling an opportunity to eat some of the healthy food options that we have available. Let's also thank him and congratulate him for a wonderful job for his presentation.
Thank you.
Thank you, sir.